Let's do that blood pressure, and we'll show them a couple of the numbers here. Because the nice thing about the Zolls that I like from the critical care standpoint is the map.
Yeah.
So we can actually show them what a map is.
So before we get into that, let's hit the actual blood pressure button. So remember, we're dealing with these sides. This side of the buttons over here, or this side of the monitor. You're going to the arm that has a blood pressure cuff. It looks like he's flexing. Select the button. You'll see it'll say, please wait. Have that patient keep the arm still. Have him keep it straight. The more that you move, the longer this thing's going to take to read. It is very uncomfortable. So if it's taking a while, readjust, look at your patient, see what they're doing, tell them to stay still, and drop that arm.
And the big thing is with the Zoll, as long as the arm's not flexed, you can actually be bouncing up and down. They could be running or whatever, and it's still going to give an accurate blood pressure. It's mainly the being flexed is what it seems to be causing.
So now we actually have a reading. So if y'all look at the actual top, the traditional blood pressure, that's what we're looking at. That's systolic 136/90. I think we all can say, yes, I know what that is. I understand that's a blood pressure, right?
Yes, sir.
So the big thing I want to talk about here is there's a couple different things in this little option here, this little selection of the BPI area of this monitor. So again, we know the blood pressure, but right underneath that, you see the parentheses, C105?
Yes, sir.
What is that, David? What does that mean? Why is that important?
Well, that's your MAP, is it not?
Yes.
So what is MAP?
So MAP is mean arterial pressure. Essentially, it's the amount of pressure on those arteries. Is there enough pressure to get your organs to perfuse? That's the goal. There are numbers. The set number, depending on what you read, usually 60, 65 is what we're looking for.
That's for the brain.
For the brain, correct. So that's a very important number, especially when it starts coming to treatment plans.
That's right.
And correlating that to patients and what we do to make that patient better. Would you agree?
No, I totally agree with you here. And we're not trying to get down to weeds too much, but what you're looking for there is, remember, we're looking usually for a 40-point difference. Your MAP is typically halfway between that 40 point, okay? As long as your treatment plan is keeping that MAP greater than 60, do you not agree?
Yep.
Then we're actually perfusing our patients. So like if I have somebody that I'm going to do permissive hypotension on a traumatic patient here, as long as I don't have to concentrate so much on the systolic, I can concentrate on the MAP, and as long as with like a 50 cc bolus, I'm keeping their MAP at, let's say 80, then I know I'm not blowing out clots, and I'm keeping the brain perfused enough to get them to a surgery. Oh
yeah, it's an awesome number, an awesome vital sign that tells us perfusion status. Awesome. I agree with you 100%, David.
Perfect. Was there anything else we need to manipulate in that BP mode?
The last thing, and we'll kind of get into how to manipulate this, but if you look at the very bottom in the blue, in that blood pressure area, you see it has a time frame.
Yes, sir.
So it's telling me right now at 12:06, because when we did the last blood pressure, and it's saying that we did it manually. So we had to manipulate this to where we can actually set it on a setting, a timer.
Okay.
How would we do that? Why would that be beneficial?
Well, that way I don't have to have one of my people coming back every time and pushing a blood pressure button.
Correct. So when we get into that, we kind of have to define when, right?
Yes, sir.
So again, being on scene for a long period of time, you probably need one set of vital signs, meaning more than one blood pressure. So in order to manipulate that, all we have to do, remember our selectors, we're dealing with this side of the screen.
Okay.
We're highlighting the blood pressure area, hit the select button. It'll then pop up a whole other menu of options. Once you get to here, about halfway down, it says NIP mode. It defaults to manual. So every time you turn this thing on, it's going to be on manual.
Okay.
So we're going to go down to mode, select it. Once you select it, it'll go to auto. Once you do that, if you go back to your actual NIP, where your blood pressure is, the very bottom, it even says auto, and right now it's defaulting to every 5 minutes.
So perfect.
For us, important numbers, right, as far as when we want to do vital signs, that stable and unstable patient is kind of important. There is a criteria for that, right?
Yes, sir.
So for a stable patient, how often should we do blood pressures?
A minimum, according to our QA stuff, is 15 minutes.
Every 15 minutes.
Every 15 minutes.
So if we had to manipulate that and we wanted to get out of that 5-minute time frame, it's very simple. So I want to get off of that auto. So I'm now back into here where I can actually select the options I want to manipulate. Scroll down. I'm going to NIP auto mode interval. I'm going to select it. This will now give me my time bank.
Perfect.
So if I'm going to 15 minutes,
all right,
go down to 15 minutes, select it. I have now changed it. So if we go back to where our actual blood pressure is at the very bottom, it says auto every 15 minutes.
There you go.
So this thing is programmed every 15 minutes. It's going to give you blood pressure.
And remember, it defaults to 5 minutes for those trauma patients.
Correct.
Because we're assuming that those really sick patients we're going to need every 5 minutes.
Correct.
But this is a great way of doing it if we're waiting 45 minutes for an ambulance.
Correct.
You know, since we're on the screen right here, the Start Turbo Cuff was actually made for hospital purposes. And what this does is this is going to give you continuous blood pressure for 5 minutes straight. It's going to do a blood pressure. As soon as it stops, it's going to give you another blood pressure. Stop, another blood pressure. When you read the literature, hey, it's important if I was doing something surgical and they were on top of it, they're trying to chase down bleeders and stuff. For us, though, should we manipulate a start turbo cuff and potentially cause ischemia on an arm?
I would say realistically, no. Now, I understand the benefit, and I know the goal behind this when Zoll came out, they were looking at just overall, how do you get arterial pressure? What's the best way to do it? And in the field, the most definitive ways are with arterial line to be able to get those definitive numbers. We don't do that in the field.
No.
So Zoll, the way they compromised was with that start turbo cuff. To read that fluid loss, blood loss, applicable to surgeries, those type of things.
Gotcha.
Realistically, in the field, are we going to use that? Probably not.
No, because that's like putting a tourniquet on.
Yes.
And it truly is.
It's uncomfortable, to say the least.
Yeah.
And you could do further damage, potentially.
So you have the ability to do this, but this is always defaulted off.